Thank you. Thank you, Dr. Manoj and Dr. Purvi, for this gracious honor for me. I'm really overwhelmed of the joy, and it's really a most pleasant moment for me because both are my very close to heart friend. So today we shall be talking about a RSSDI which has started some new initiatives in this year. I'm really grateful of my president, Dr. Vijay Vishwanathan, who has started giving me free hand to do the work, whatever I wish to start, even when I have not taken the official position of the president. So I'm really grateful of him. With that, I shall be telling you this this year RSSDI had thought that we should screen all diabetes patients for their blood pressure. And for that purpose, we designed a study of impact of population-based screening among the RSSDI members, those who were seeing the patients with diabetes and what their blood pressure is being looked after and what is the level and multiple information related to their blood pressure. So this is for the first time I am going to disclose the findings of that study. So I think this is another opportunity for the DRS conference, which is getting for the first time these RSSDI findings. So what exactly is the RSSDI 10:10 BP challenge? It was a hypertension screening in type 2 diabetes. We thought that RSSDI is having 12,000 members. So in 10 days, if one member screens 10 patients in a day, then we can have at least 10,000 in 10 days. With this concept, we thought that in 10 days, 10 lakhs people can be screened for that. Although practicality may be a little bit different, but whenever you keep your target high, then obviously you achieve certain part of that, which is also very high and very impressive. So these are the few pictures where you can see that we went in the urban areas, we went into the rural areas, we tried to get the blood pressure checkup in women as well as in the male population. This is one of the village nearby Lucknow where our person is checking the blood pressure of the women. The background of behind this initiative was, of course, everybody knows that hypertension is a major big challenge and it's a public health problem. More than 1 million people worldwide. In India, it accounts for 10.8% of the all deaths and 4.6% of the life years of the people. And type 2 diabetes prevalence rising, that is well known to everyone. We are having the 11% population of the India is suffering with the diabetes, but at the same time, about 35% population of the India is suffering with hypertension. And once these are existing together, they are creating a big risk, which is not actually the 1 plus 1, 2, that is the 1 plus 1, 3. So population level screening is essential, found to be address this dual epidemic. 30 to 60% of people with type 2 diabetes have the coexistent hypertension, which has been proven by the previous studies before this. Nearly half of all adults with diabetes develop hypertension during their lifetime. And coexistence of especially common in older age groups and obese individuals is frequently seen. So why does it matter? As I already said, cardiovascular adverse outcomes are going to be more than the combination of the two. Chronic kidney disease and progression to the ESRD is much faster and more if a person develops hypertension in a setting of the diabetes. Retinopathy and other microvascular complications, and there could be the major driver of the disability, premature mortality, and healthcare burden to our system. What is the pathophysiological connection? If we look for the hypertension in a patient with diabetes, two things must be understood to all of us. Both the diseases are having the common soil of the origin, and that common soil is the insulin resistance. Second thing is that both the diseases are taking almost similar path and ending up with the almost same complications, and these complications, especially the macrovascular complications, are carried forward through the atherosclerosis. So once the insulin resistance is there, it induces the sympathetic activation and sympathetic overdrive, which helps in retaining the sodium. And this starts with the hypertension development. This starts with the rising of the blood pressure. Vascular tone changes. Then endothelial dysfunction starts and RAS activation goes high. That causes more of the arterial stiffness. We all understand with the passage of the time as the age advances, this is the arterial stiffness which is responsible for high blood pressure. So once a person grows to the 50 or 55 years of the age, arterial stiffness gives rise to the high blood pressure. But in a diabetic patient, because of all these reasons, it comes much earlier. Even in 25 years of age or 35 years of the age, people develop arterial stiffness high and they develop blood pressure rise. Obesity, oxidative stress, more of the inflammation, they are the amplifier of this hyperglycemia together with the hypertension. Ultimately, a vicious cycle develops where we see that diabetes is causing hypertension and hypertension is giving rise to the diabetes. Both are accelerating each other as well as both are accelerating the occurrence of the complication when they are together. So what the studies has been done previously before we met for this one. Blood pressure and the risk of developing diabetes in the African Americans has been studied as well as it has been compared with the white. What this ERIC study says, which has been studied in the atherosclerosis communities, the Framingham Heart Study concluded that hypertension is a risk factor for the diabetes and can proceed to the development of the diabetes. In the Framingham Heart Study, due to fourfold increased risk of the hypertension has been observed among individuals with type 2 diabetes. Means if a person is developing type 2 diabetes, not keeping good control, obviously the hypertension is the most likely thing to occur earliest in his life. If we talk about the India, we can see that studies in India have shown that hypertension has been associated with approximately 57% of the stroke death and 24% of coronary heart disease. Urban areas have a prevalence of 25% and rural areas have about 10% prevalence of hypertension in India. There has been the management of the hypertension which has been seen giving rise to the chronic kidney disease as well as those who are already existing with the chronic kidney disease and developing the hypertension. So there has been a study which has stated that hypertension is closely associated with chronic kidney disease, which is further linked to the diabetes, and deterioration of the kidney function can worsen hypertension and vice versa. There has been a study which was on the variation in health system performance for managing diabetes among states in India. Cross-sectional study of individuals aged between 15 to 49 years. But this study has really brought me to the idea that why won't this study to be done by the Indian people for the India? Why so many the foreign authors are involved in this study? Can't we do this kind of the study through the RSSDI by our Indian authors? So looking over that, the idea arises that we should plan this kind of the study either on the RSSDI or on some combining with some hypertension platform. So we could found that unmet needs of the both diagnosis, treatment and identification of the hypertension related complication is higher among poorest and rural population in India. So this rationale for the population level screening arisen out of all these studies, and what we could see that significant proportion of the hypertension cases remain undiagnosed or inadequately treated in India. Early detection, the people with type 2 diabetes allows for the timely intervention to prevent complications. It also allows for the identification of the high risk groups. Really, we can reduce the morbidity and mortality at lowest possible health cost. Very few large-scale screening programs target hypertension and diabetes in India. Comprehensive screening across age groups, risk profiles, and treatment status is very much needed. That's why this study, which has been planned as the RSSDI 10:10 BP in patients with diabetes, this study is the largest nationally representative screening initiative for hypertension in type 2 diabetes patients, with the aim to determine prevalence of hypertension risk factors and comorbidities among individuals with the diabetes, which was having the primary objective to determine the prevalence of the hypertension in individuals with diabetes, with the secondary objective to identify risk factors among individuals with both hypertension and diabetes. And we wanted to document associated comorbidities like CAD, stroke, chronic kidney disease, and dyslipidemia, etc. also together with the hypertension and diabetes. So this study has been designed as a cross-sectional population-based study, which was having conducted in India. The study period was kept for the 10 days nationwide campaign, which has been extended for 10 more days. sample size was looked after for the 10 lakhs, but later on we could screen actually the 2,07,347 patients. Inclusion criteria was all individuals who were having the diabetes of more than 18 years age have been checked for their blood pressure. Individuals less than 18 years have been excluded, although the people, those who were unwilling to give their consent. The data has been collected for the demography, age, sex, education, occupation, socioeconomic status. We also collected the anthropometric data, height, weight, BMI, waist circumference, clinical profile like duration of the diabetes, hypertension status, family history, addictions, stress level. Comorbidities have been noticed, like if the patient is having the CAD beforehand of the coming to the investigator, CVA, CKD, dyslipidemia, hypothyroidism, obesity. Also, recorded a medication history, what the antihypertensive are being used or the first time has been detected the hypertension, or if the patient was known for the hypertension but never taken the medication. Optional tests were also being kept for the patient, those who were looking for that and those who were agreeing for that, like blood glucose, HbA1c, creatinine, and urinary ACR has also been kept and has been done in a good sizable number of the patients. So this was the BP measurement protocol which has been established and already accepted by the International Society of Hypertension as well as ADA, in which we used the device which was the validated oscillometric upper arm cuff, and cuff selection was the as per the size of the arm, 80% of the arm circumference, and patient has been prepared as per the protocol given by the International Society of Hypertension. Ethical clearance has been taken, informed written consent has been taken or confidentially maintained, data anonymized for the analysis, no risk for the financial burden of participant, and results to be used purely for the academic and public health purpose. Let's come over to the results of the sample profile. Age and gender. Here, this was the 2,07,347 patients of the diabetes has been screened for their blood pressure. What we could see here that people, those who were found to be hypertensive, were 3.5% in 18 to 30 years of the age, and highest the more than 60 years of age, which was well accepted. 41.3% female and 58.6% male. BMI and waist circumference was noticed at 41.2 in the those who were in the obesity class 1, with having the maximum level of the hypertension, and male-female difference was not very much significant here. If we talk about the education level, various education level were there, but what we could see that highest amount of the hypertension could be seen in the higher secondary people and those who were not having the any formal education. So people, those who were higher secondary and those who were not having the formal education were not very much different, but this was quite astonishing that people, those who were having the higher secondary education and graduate, and when we combine both of them, they are actually making a big chunk of the hypertensive population in our diabetic population. The same with the occupation status. People have been divided as per their occupation. Homemakers have been found to be on the highest risk of the hypertension as much as the unemployed individual. We can always understand that unemployed people may be having the hypertension because of the stress of their life and because of the unemployment. But homemaker females, those who are working in our houses, they have been found almost equivalent risk of the hypertension, followed by the people, those who are working in the private companies, and then daily wage workers who are having the 11%. Government job people were found to be the least in the hypertension, 6.5%, retired were 6%, and students were the 2.5%. Let's talk about the prevalence of hypertension in type 2 diabetes. 41.1%, 58.9% were having, 58.9% were not having any history of hypertension, but they were found to be hypertensive. 41.1% those were who were having the history of hypertension, those who were knowing that they are hypertensive. If we talk about the age group distribution, this was the age group distribution. Again, the 60 plus years were having the highest amount of the hypertension. Prevalence by the BMI group again was the highest in the obesity class 2, followed by the obesity class 1. In earlier, we could see that obesity class 1 were found to be the highest hypertensive patient. So once we have compared with the hypertension versus no hypertension individual groups, controlled and uncontrolled. So uncontrolled hypertension was there in 34.4%. Controlled hypertension was the 65.6%. If we divide with the grading of the hypertension, what we could see that those who were having the history of hypertension were having 31.8% grade 1 hypertension, 9.5% grade 2 hypertension. While the people, those who were having no history of hypertension, were having lesser grade 1 hypertension as well as lesser grade 2 hypertension. But more important was that those who were having the history of hypertension, those who were knowing that they are having the hypertension, they are also having high uncontrolled rate in all the segments, may it be the high normal BP, may it be the grade 1 hypertension, may it be the grade 2 hypertension. Anthropometry, obviously the BMI, waist circumference, prevalence of obesity, they were found to be more in the patient those who were having the history of hypertension. Lifestyle factors like smoking, alcohol and diet type. So smoking is definitely found to be a major driver for the hypertension, although alcohol was found to be not significantly playing a role. Smoking is more common among those with hypertension, 51.7% versus the 44.4%, while alcohol use is similar between the group, those who were hypertensive as well as those who were not hypertensive. Diet distribution of the vegetarian and non-vegetarian diet is identical across the group. Suggesting no dietary pattern difference could be noticed with the hypertension status. Stress, as much higher proportion of the hypertension individuals report experiencing stress regularly, as we could see that 61.1% compared with the 28.6%. Those without hypertension are more likely to report stress. Rarely we could see that 40.9% when it has been compared with those who are having the hypertension, 32.6%. The duration of type 2 diabetes, presence of comorbidities are also compared in the patient those who are having the history of hypertension or no history of hypertension. History of hypertension, we had that more than 5 years duration of diabetes in the 57.1% individual. Those who are not carrying any history of hypertension, having the hypertension more than 5 years, hypertension 44.7. Similarly, the no comorbidity could be seen in 29.3% in history of hypertension, but at least one comorbidity was there, 47.7% of the no history of hypertension. So among those with hypertension, a higher proportion level had type 2 diabetes for more than 5 years compared to those without hypertension. Individuals with hypertension are more likely to have at least one additional comorbidity, 70.7% compared to those without hypertension, 52.3%. Results of the known hypertension individual, antihypertensive medication. 13% have been found they were not taking any medication despite knowing that they are having the high blood pressure and hypertension. 87%, it is good figure. 3-4 years before, when we did the same kind of the survey among the May measurement month, we found that about 50% people were not taking their medication despite knowing their hypertension. But that was in the general population. This time we did in the only diabetic population. Majority of the people were on the angiotensin receptor blocker, means people are using the RAS blocker in India, especially those who are having the diabetes, 46.2%. I must say this, in a study which has been done in the people, those who were followed for the overall hypertension, we found that calcium channel blocker was the more choice among them for the blood pressure control. But in diabetics, we could see more used ARBs followed by the CCBs. Then 25.4% also used the beta blockers, and diuretics has been used 19.1%. And if we combine the ACE inhibitors and ARB, then probably the combination makes a big amount of the RAS blockers, which is being in Indian diabetic patients for the hypertension management. 87% of the patients are on the antihypertensive medication. Among those treated, the most commonly prescribed drug class is the ARBs at 46.2%. So, in summarizing, in the known hypertensive individual, the RSSDI 10 into 10 BP challenge is the largest population-based screening of hypertension in diabetes ever conducted in India. 207,347 participants. 41% of the people with diabetes reported a history of hypertension. Hypertension prevalence rose with age, 18.3 in 80 to 30 years and 52.9% more than 6 years. And with BMI, those who were having the lesser BMI, they were having the lesser blood pressure. Those who were having the higher BMI, they were having the higher blood pressure. So BMI is also playing a guiding role for development of the hypertension. Considerable proportion of the individuals with known hypertension remained uncontrolled, 41.3%. Alarmingly, 29.6% of those without a prior diagnosis were detected to have elevated blood pressure during the screening. So we can say that around 30% population of the diabetes individual is still not knowing about their high blood pressure. Findings confirm that undiagnosed and uncontrolled hypertension is a major hidden burden in Indian diabetes patients. Population-based screening models are feasible and impactful in detecting large pool of the undiagnosed and uncontrolled hypertension. Such initiatives can enable early diagnosis and intervention in high-risk group. Probably many of the patients, those who have been undergoing to this screening, could first time realize that they are having a very important risk factor which they are not really addressing. Many of the doctors would have also realized that probably they are not measuring their patient's blood pressure appropriately, so they are missing this. This kind of the initiative provide data for the targeted public health strategy, reduce long-term burden of the CVD through CKD and diabetes population. RSSDI 10 into 10 BP challenge demonstrate the power of professional society, led nationwide campaign to bridge critical gap in detection and management. And this power was of you. You people, those who are the member of the RSSDI, has actually run this. This time, this drive, we have not opened it for the non-members of the RSSDI. If we could open to the non-members of the RSSDI, probably the data would have been much bigger. But again, it was that we wanted to do in the among the people, those who are the part of the society and they can be held responsible for any data collection, whatever they are doing. Calls for the integration of the routine BP screening into the diabetes care at all levels of the health system. This initiative also reinforces the need for policy level adoption of community-based screening program for dual epidemics of hypertension and diabetes in India. The ultimate key take-home message is hypertension is highly prevalent among people with diabetes in India, affecting 4 in 10 with a strong age and obesity link. Nearly one-third of the patients were newly diagnosed during screening, highlighting the hidden burden, and that hidden burden is need to be bring out. Uncontrolled hypertension remains common even among those who are taking the treatment. Population-based screening works. Large-scale society-led initiatives like the RSSDI 10 into 10 BP challenge can bridge gaps in detection and control. Routine integrated BP screening in diabetes care is essential to reduce future CVD, stroke, and kidney disease burden in India. In fact, if we really wish to reduce the complications of the diabetes, hypertension screening is very important tool that is to be used to reduce the many of the patients who could be saved going into the kidney failure, going into the cardiovascular adverse outcome, going into the many sympathetic overdrive related complications, and finally we can also stop the cerebrovascular disease. Thank you very much for your kind listening.